Good morning and welcome, everyone. So it's my pleasure this morning to introduce Dr. Erika to speak. Dr. Nass is an assistant professor of medicine in the Division of Rheumatology, and she serves as a teaching attending on the UWMC Rheumatology Consult Service, as well as has clinic at the Roosevelt Clinic in Rheumatology. Dr. Nass earned her MD as well as her PhD in immunology at Case Western Reserve University in Cleveland. This was followed by internal medicine residency and rheumatology fellowship at Brigham and Women's in Boston. Dr. Nass then joined the faculty at Harvard Medical School until 2014, when we were lucky enough to have her join the faculty at the University of Washington. Dr. Nass's research has focused on understanding how fibroblasts contribute to inflammation and tissue pathology in autoimmune disease. The mechanisms that drive fibroblasts to become fibrotic or inflammatory in tissue is poorly understood, and so the long-term goal of her lab is to define fibroblast differentiation pathways to target autoimmune disease treatment. It is with this research background that she comes to us today. So please join me in welcoming Dr. Erika Nass as she presents Looking Inside the Joint, Lessons from RA and OA Synovium.
Thank you. It's an honor to be asked to speak here today, and I'm going to do something we don't usually do in rheumatology, which is try to talk about rheumatoid arthritis and osteoarthritis in the same talk. And so I want to go ahead and start with just how rheumatologists think about arthritis in general. And I think I'd like you to just sort of point out here that if anyone has, as you all know from our rheumatology inpatient consult notes, rheumatologists are not the most decisive people in the world, and so we can't even agree on how to separate our own joint diseases into non-inflammatory and inflammatory components. But somewhere, what we think about is the synovial fluid white blood cell count, and somewhere below 1,000 to 2,000 white blood cells, you have non-inflammatory disease. And above this, you have inflammatory disease. And the major non-inflammatory disease is osteoarthritis, and it goes by many names. Another thing from rheumatology you'll note is that the more names we have for something, the less the less we understand that disease, right? So it's osteoarthritis. We refer to it as wear and tear arthritis, degenerative arthritis, and if you go into the spine, I think there's about 5 different names for it: spondylosis, facet arthropathy, et cetera. So this is osteoarthritis. Moving into the inflammatory side, there are the non-autoimmune causes of it, and this is infection and crystal disease, which I'm not talking about today, and then the autoimmune causes. And I'm going to talk today mainly about rheumatoid arthritis because that's one of my major research areas, and also it's one of the most common types of autoimmune arthritis, and I think we understand the best about that. But other autoimmune arthritis include psoriatic arthritis, ankylosing spondylitis, and reactive arthritis. So I thought I would start with RA and just give you a sense of the faces of RA and a little bit about the epidemiology of RA through a patient I saw a few months ago. And this woman is a 37-year-old smoker, and she's referred for RA, and this is just what I saw when I read the chart before she came in to visit. So just in terms of the epidemiology of RA is 2 to 3 times more common in women. It's actually more like 3 times more common in women under the age of, and patients under the age of 50. The most common age for the peak incidence of RA is between 50 and 70, and there's still a gender, so it's probably more than like 1.5 to 2 times more common in women. Another major thing we see here is smoking. So smoking is an extremely strong risk factor for seropositive or antibody-positive RA, which we'll talk about in just a second. And she presents with a polyarthritis. So she had visible swelling in her hands, elbows, knees, and feet. The common joints involved in rheumatoid arthritis, and had been there for almost 7 months now. And timing is critical in diagnosing RA, right? So you can't get an RA diagnosis by criteria unless it's been there for at least 6 weeks. So this is really a chronic disease, not an acute disease, and this helps us separate it out from a reactive arthritis from, for example, a parvovirus infection. And this is the main thing we look for clinically when we talk to our patients. So it takes her, she's 37 years old, it takes her several hours to get going in the morning, and oftentimes young RA patients I remember very distinctly, it's a psoriatic arthritis, not a rheumatoid arthritis patient, but she was a medical student I saw at Harvard. And she would get up at 5 o'clock in the morning so she could loosen up enough to get to her classes at 9 or 10. So really what you have is this profound morning stiffness, this feeling that you just can't get going. And the morning stiffness lasts for at least 30 minutes, but oftentimes several hours or never disappears throughout the day. And she, when I looked through her labs, had high titer positive rheumatoid factors and anti-CCP antibodies. And so these are our RA tests. And like most tests in rheumatology, they're okay. Perhaps we need better tests. So both of these tests are not terribly sensitive. They're present in about 70% of RA patients. So about a third of RA patients will have rheumatoid arthritis without antibodies. Of the two tests, rheumatoid factor is the less specific, so it can also be elevated in chronic viral infections, endocarditis, anything that sort of tickles your B cells, lymphoma. Our anti-CCP antibodies, especially at high titer, are actually highly specific. So in the right clinical setting, like this patient, a high titer anti-CCP antibody is nearly diagnostic for rheumatoid arthritis. And this is not her hands, but this is what her hands looked like. So just looking at her hands, you can see a classic area of involvement in RA are the MCP joints, right? And usually your knuckles are higher than the space in between the knuckles. It's reversed in this patient, so there's clear MCP swelling. And you could also see, just comparing her fingers, that she has thickening across the PIP joints. So on exam, she had visible swollen joints in her hands and her feet. And so when she came in, I was actually pretty convinced of the diagnosis, and then the question becomes, how do we treat it? And I want to just talk for a few minutes about what we do for treatment, the successes we've had, and some of the places where we still need to improve. So our workhorse in rheumatoid arthritis is low-dose methotrexate. And so we have our first box, which I call our DMARD box, DMARD standing for disease-modifying anti-rheumatic drugs. And we usually start with methotrexate, and we can add to methotrexate other oral agents. Or if they're not doing well, we can go to our second box, which is our biologic or small molecule inhibitor. And these are more targeted immune therapies. And we have now, as you can see here, 6 different families of these approved for rheumatoid arthritis. The first that was approved are the anti-TNF drugs, adalimumab, etanercept, infliximab, et cetera. We also have a drug, abatacept, that works against T cells, specifically blocking T cell co-stimulation. We have drugs that block the IL-6 pathway. We have rituximab, an anti-B cell drug, is also approved for RA. The newest kid on the block are the JAK inhibitors. So these are small molecule inhibitors that block cytokine signaling pathways. And finally, anti-IL-1 therapy is approved for RA, although it's a pretty weak drug and is not usually used in RA. So we take one from this box usually, one or more from this box, and if we need to, we add from this box. And so how do we do? Well, we've had a lot of success. So what we're getting better at is preventing this. So this is a classic hand of a patient with long-standing untreated rheumatoid arthritis, and you can see the classic features, enormous involvement at the MCP joints, to the fact that these joints are now subluxed or chronically dislocated, along with finger deformities from PIP involvement and thumb involvement here. So our rates, it's more and more rare to have patients walk into our office with hands that look like this. And many of the rare complications from untreated rheumatoid arthritis, for example, rheumatoid vasculitis or Felty syndrome or bad eye disease, are also decreasing infrequently. Interestingly, and I'm not going to talk about it today, I just want to point out that not all of the extra articular manifestations of RA have disappeared, and the incidence of RA lung disease may actually be increasing, right? So there's still much we don't understand about this disease. So, but I just want to take you through this busy slide because this sort of, to me, these are, as I was sitting here typing up this presentation, 4 patients that sort of popped into my head, and I want to just, and I think they highlight anecdotally some of our problems with RA treatment. So we'll start with our first patient, the 37-year-old woman that I presented, who has positive antibodies, a polyarthritis, high disease activity at start. I've now given her methotrexate. She's been on it for a couple months. I saw her just recently. She came back very happy. Now, her feet still hurt her, and she had one very swollen PIP joint, but overall her disease activity was low, and she had a good response. This is another patient I saw at the University of Washington now for a couple years. He's a man who's seronegative, but still has polyarthritis, also started with high disease activity. And we started him on methotrexate. It didn't quite cut it, so then we added more oral agents, and he got better, but not perfect. So we switched him again, and he remained not perfect. And now we've switched him a third time, and he remained not perfect. So he's better, but he's far from being in remission. This woman here is a woman with a strong family history of RA who I saw in Boston, seropositive polyarthritis, who had very high disease activity, and we went through at least 4 or 5 treatment options over a couple years, and we never got out of high disease activity. And then finally, this woman here has an odd pattern. She's seropositive. She has more of an oligoarthritis pattern, which happens in RA. It looks like she was like this woman. We went through all of these different treatments over a couple years, and we finally got to rituximab, and then her disease went in remission, right? So I have 4 patients all getting optimal treatment, and we have a spectrum of responses and very little remission, true remission. And this is actually shown in clinical trials. So this is taken from a review from Lancet in 2016. And these are graphs they made from all of the clinical trials, phase 3 trials, testing these different biologic or small molecule inhibitor drugs. And so all of these, I'm just showing the patients who have never been treated because their response rates are actually better than people who've been on a medication before. So all of these patients got methotrexate and either methotrexate alone or methotrexate plus one of these agents, right? And we're not looking for remission. We're looking for something called an ACR70 response. So this is roughly a 70% improvement in the number of swollen and tender joints. And that's considered a great response in rheumatology. And you can see with methotrexate alone, we're getting about 15 to 25% ACR70. And when we're adding the biologics, we get a statistically significant improvement. But we're not even reaching 50%. And there's no significant differences across all of these biologics. So we have more and more drugs. And as we use each of the drugs in big trials, we're getting to sort of the same response rate. And so one of the things you could say, well, just add more drugs, right? And so we tried this. This was a trial looking at a TNF inhibitor alone or adding this anti-IL-1. And what we found, this is just a 6-month randomized control trial. And with the TNF alone, our serious infection rate is quite low. When you combine two, our serious infection rate went up to 7.5%, just over 6 months, and there was 1 death from sepsis, right? So this is greatly decreased the enthusiasm of rheumatologists for combining more and more of these targeted, powerful immunologic agents. So where are we? Well, we've switched our research to thinking about, can we personalize this medicine more, right? Can we get better predictors of how people respond to treatment? So I'm going to talk about that first as an area of ongoing research. So currently, we have nothing that really personalizes treatment. I think our best sort of prognostic thing in rheumatoid arthritis is an anti-CCP antibody. So the 70% of patients who have a strong titer anti-CCP antibody in trials are much less likely to go in remission. They have a higher risk for joint damage. And actually, interestingly, they have probably better response to our T and B cell therapies. But again, these are on population basis, nothing you can use to predict an individual response. People have re-looked at some of the oldies but goodies, and for example, this was an abstract from our recent meeting. C-reactive protein, I think I'd like to point out that you can have bad rheumatoid arthritis and have a normal C-reactive protein. And these patients, when they look at them, have active swelling by ultrasound, but they appear to be more treatment resistant, again, suggesting maybe it's a different disease. And I think as rheumatologists, we realize that RA isn't just a disease, it's a syndrome of diseases. And I'm going to show you some evidence of this in the tissue, right? Because I trained as an immunologist as a PhD, so my whole focus was on how autoimmunity goes astray. And then during my postdoctoral research, I was taught that autoimmunity is a two-way street, right? So your immune system can do what it wants, but if your tissue doesn't respond to that immune system, you don't get disease in a particular place. And so I'd like to talk about how the field in RA is moving to looking actually inside the tissue in addition to the systemic immune response to perhaps predict how people do in disease. So to look inside the tissue, of course, we have to review what the tissue looks like. And so this is a histological slide of the synovium. And so a joint is a place where bone, which is capped by cartilage, meets another bone that's also capped by cartilage here. And the site of action in rheumatoid arthritis is the synovium, which is this tissue that lines the joint space here. And the synovium's job is to make synovial fluid, which nourishes the cartilage and also adds molecules inside the synovial fluid like hyaluronan and lubricin, which reduce joint friction, so you can move your joint more efficiently. And so this is what a normal synovium looks like in a closer view. And it's an interesting structure in the biology. It has, not that because it has a lining and a sublining, but because of what the lining is composed of. So we think of most lining layers as epithelial cells or endothelial cells. But in the synovium, it's actually this mixture of macrophages and fibroblasts, making this very thin lining layer. And then underneath this is typical loose connective tissue. And in rheumatoid arthritis, you get marked changes in the synovium architecture. And so these are pictures from 3 different patients showing some of the different findings in rheumatoid arthritis. So what you get is lining hyperplasia. So it's hard to see, but this lining layer goes from 1 to 2 cells thick to this several cell thick compacted mass. And you get infiltrates, immune infiltrates inside the sublining. And most of the time, the immune infiltrates are diffuse, but sometimes they actually form things that look like tertiary lymphoid follicles, something you might see in the spleen or the lymph node in subsets of patients. And then this lining here, when it gets near cartilage and bone, behaves less like a normal tissue and more like a tumor in that it begins to erode away into your cartilage and bone. And this is often we refer to as pannus, and this is what drives a lot of the cartilage damage in rheumatoid arthritis. So I wanted to draw attention to this study that came out in 2014, and there's more data coming out all the time. But in this study, they took probably 2 cohorts of RA patients, somewhere between 60 and 80 patients, and they took synovial tissue samples, and they used gene expression profiling to did gene expression profiling in the synovium for multiple patients, and then looked to see if they clustered into different phenotypes. And what they found phenotypically is they saw patients who looked like they had more like a lymphocyte signature with a lot of IL-17 signaling, T-cell receptor signaling, B-cell activation. They had stuff that looked more like an innate immune signature with lots of TNF signatures and IL-1 signatures and toll-like receptor signatures. They had something that didn't look like much of anything. They call it response to wounding was the major thing that came up. And they had stuff that looked like more like a fibroblast signature with bone morphogenic protein signaling, SMAD signaling, TGF-beta, things that we think of being involved in fibrotic diseases, actually. And then they took these signatures and they went and they characterized their histology. And here I'm showing you their examples of 4 different patients. And in here we've stained for CD3, which stains T cells, and CD20, which stains B cells. And they saw a correlation between, perhaps not surprisingly, the gene signature and what the tissue looked like. So those with the most lymphocyte signature are the patients who are more likely to have immune aggregates that form things that look like lymphoid follicles. The myeloid ones had less T cells and B cells. By flow cytometry, they had more CD45 positive myeloid cells, which I'm not showing. And then they had these 2 other types that they refer to as either low inflammatory or fibroid. And roughly, about half of the patients had sort of this immune leukocyte-rich or immune-activated population, and about half had this sort of low inflammatory or fibroid population. And a lot of the argument when the study came out was that these are just burnt-out disease. These don't represent true disease, right? They're end-stage disease. Well, they have not published the data yet, but it was presented at our most recent meeting that they have done synovial biopsies from patients with very early disease where they can look by ultrasound and prove that they're actually active. And still a substantial portion of these patients come out with what looks like these gene signatures, suggesting that these are actually truly a disease phenotype and not just end-stage disease. But this is a matter of some controversy in the field. So does this really matter? And this is these are very crude scores, but these are their patient cohorts and looking at response to an anti-TNF therapy. And this is using the European grading system where you grade people either as good, moderate, or poor. And what they found is that if you group them by patients who had more a myeloid sort of innate immune activation signature, there was a statistically significant increase in the number of patients reaching good response, although you can see the error bars are huge as this is a small trial. Whereas we saw less response to anti-TNF therapy with either a lymphocyte or even more particularly with a fibroid score, which again is, I think, I'm showing this because it fits in with our sense from clinically that there are subsets of patients who respond well to certain types of therapy, like the patient I showed you who responded particularly well to a B-cell therapy and nothing else. And I'm showing you this because we're beginning to get a handle on perhaps some of the things that are driving this, but we have a long way to go yet. So I would say, sort of in summary for this section, that this is, I'm showing you this for RA, but you could probably put any autoimmune disease up here, right? Autoimmune diseases, we call them diseases, but in reality, they're syndromes. And we're going to need a treatment response algorithms, I think, that take into account multiple boxes, including your clinical variables. In RA, we know demographics, body mass index is a risk factor for seronegative RA, for example, disease duration, presence of erosions, all perhaps phenotype patients. We have blood markers, the ones we know about, CRP, cytokines, gene expression. Genetics plays a huge role, and there are genetic risk variants we should take account for. And then, of course, where I'm adding on here these tissue responses, which is an area of interest of mine. Going actually inside the tissue, taking synovium out, and seeing what is the cell composition and the gene pathways there, and does that make a difference and help us predict patient responses better. So I'm going to switch gears now and go on to something that's a little closer to what I do, though not for very long, in the RA field. I'm going to talk about novel treatment targets. And I often get this, so why bother? Don't we have plenty of drugs, right? I just showed you we have like 6 approved biologics here, right? But I also showed you that we've sort of reached this treatment impasse and they all behave similarly. So is there something we're missing? Is there something else that we can target in disease? And I would like to point out here that our current drugs all target inflammatory pathways. But about 50% of patients have what is a posse or immune or a fibroid phenotype, right? And there is some argument about how real this is, but these two things I would put up to you don't match up, right? So one of the things we're working about in the lab is changing our treatment paradigm so that we target both immune cells and we target these cells called synovial fibroblasts. And so why are we interested in synovial fibroblasts? Well, I showed you this before. The synovial lining is made up of macrophages and fibroblasts. And when you get activated synovium or pannus, this is hyperplastic. You have an increased number of activated macrophages and fibroblasts. And we know that when you take a normal synovial fibroblast and you, honestly, if you look at a normal synovial fibroblast, just look at it funny, it does stuff. But the usual things that are things, so cytokines, growth factors, prostaglandins, various immune surface interactions, various damage matrix products, hypoxia, all activate the synovial fibroblast. And what they effectively are is an innate immune warning cell. So when something's wrong in the joint, I sort of view them as a siren. The fibroblasts scream. And they do things like make lots of cytokines and chemokines that bring in immune cells. They also make growth factors, prostaglandins. They upregulate immune molecules such as CD40, which can be important in immune interactions. And they also make lots of degradative enzymes. And so fibroblasts make lots of things that look like they're important in RA. And we have now multiple pieces of in vivo evidence, and I'm just showing you one that came from the postdoctoral lab I worked in, that if you take away some fibroblast functions, you can actually alter disease in vivo. So this is looking at a cell-to-cell adhesion molecule, cadherin 11, that's specifically expressed in fibroblasts in the synovium. And we have mice here that are wild-type mice or either knocked out or don't have cadherin 11. And we do mouse arthritis, and my other job is a mouse arthritis doctor. So you go down there and you score mice just the way you would do a human. You pick it up and you mark is the joint minimally, moderately, or severely inflamed, and you get a score maximally of 12 because they're score plus. And so as you can see, wild-type mice in this arthritis model get loss of arthritis, and if you don't have cadherin 11 there, you get less arthritis. And the surprising thing that came out of this study, actually, is that in these mice, so this is a marker of inflammation. In these mice, they actually had equivalent amounts of bone erosion. But these mice were actually pretty uniquely protected against cartilage erosion, which was sort of one of the first in vivo studies in the field to suggest, first show that fibroblasts made a difference in an arthritis model, and to really give us evidence that fibroblasts are playing a role both in amplifying inflammation and also directly damaging cartilage. So just to not belabor this point, I just want to point out to you now that this treatment paradigm that I proposed to you is actually being tested currently in a phase 2 trial. And an anti-TNF agent is being tested either alone or in combination with cadherin 11 to see if we can improve treatment by targeting a different method. So for the second half, so I'd just like to, before I switch gears and talk about osteoarthritis, I'd like to just summarize what I've talked about here in RA. So I would say there's lots of hope in RA. We have new drugs, we get better treatment, but we still hard to achieve true disease remission. And RA, like most autoimmune diseases, are syndromes with multiple patient phenotypes, and we have a large need for patient-directed treatment algorithms. And finally, I've showed you some new data, which we're excited about, that targeting non-immune cells or resident cells in autoimmune disease in combination with the systemic immune response may actually help us improve treatment. So, black slide, because I'm doing my major gear switch and going to another patient. This is my reading epic before the patient comes in. So this is a 57-year-old heavy machine mechanic who's referred for diffuse joint pain in his shoulders, back, hip, knees, and feet. And go through his x-rays and MRIs, of which he's had multiple, and we've all seen these. So in his hand x-ray, he has degenerative changes in his DIP, PIP, and first carpometacarpal joints. He has a shoulder x-ray, and he has a acromioclavicular joint osteophytes. His knee x-ray has tricompartmental narrowing and osteophytes, and he has a lumbar MRI that shows multi-level degenerative disease. And you get this, I will admit it, I get sometimes this little slightly sick feeling in my belly because you go through his problem list and you're like, hand OA, can we do much for it? And then you go, okay, how about the shoulder? Well, maybe there's some rotator cuff stuff. Maybe he'd get a steroid injection there. And then you get a little excited when you get to the knees because I could potentially send him to the surgeon and they could fix the problem. And then you get to the back and I'm like, oh. And then the patient comes in, right? And so I would just like to start, before I go back to how I approach these patients, right? I don't want to leave you without any hope. I want to talk to you. Osteoarthritis is really, we call it a disease, but it's really a radiographic diagnosis, right? It's basically joint failure by x-rays, right? And so what's happening, right, in my very simplistic, non-orthopedic rheumatology view of osteoarthritis? So somehow you start with a joint that the mechanics alter, and we'll talk about that, and that leads to tissue damage, and you might get pain, and then it heals. But that tissue damage has altered the mechanics just a little bit more. And so something else happens and you get more tissue damage and pain, and then it may subside for a while. But your mechanics are altered, right? Setting you up for a potential bad cycle, which ultimately may lead to joint failure, right? So what alters mechanics? And in some ways, OA is a more heterogeneous disease than RA, if you think about it, right? So some people get OA because their anatomy is a little funny. Their hip impinges in the wrong place, or they're a little varus or valgus in the knee. Some people get OA because they were skiing and tore their ACL, and even though they repaired the ACL, there's still a 30 to 40% risk of developing early OA. Some people get OA because of obesity and increased load. Some people get OA because there's something wrong with their extracellular matrix, and often these we don't. Some of them we know, most of them we don't know. There are other genetic components that we don't understand. And then honestly, true, like the lady I saw you, she, with the deformed RA hand, she also has osteoarthritis, right? It's a secondary OA that came from autoimmune joint destruction, right? So there's many pathways to osteoarthritis, which makes it in some ways difficult to know where to intervene. But this is what we do in clinic, right? So my patient who comes up with his 4 sites of RA, And a lot of talking to these patients is not, I think you have to be realistic. You're not going to fix a lot of their OA, right? So a lot of it is, what do they want to do? What do they want to get out of life? How can you help them improve some of their function, right? And so how do we do that? So, well, ideally, we'd want to change the ultramechanics. Oftentimes, by the time they get to clinic, the mechanics are so altered, there's not much to do. But there is value to physical therapy. There is value to weight loss. Surgery is definitely an option, especially for hips and knees, and to some extent for shoulders. Sometimes bracing helps. I think we don't really understand a lot about how to use bracing, but talking to our sports medicine colleagues or the physical therapist can help, especially with knees. There's some intermittent always excitement about modifying shoes if you have altered mechanics, but it's always important to have good shoes, so that's something you can always talk to patients about. But in general, a lot of these, by the time we see the patients, is a little bit too little too late. And the other thing we have, of course, if there's not much we can do here, can we control their pain? And we all know here how difficult and challenging that is. We have over-the-counter meds, tramadol. You can add neuropathic meds as an adjuvant. There's topical steroid injections. And then I think truly we underutilize the pain clinic and pain psychology, right? Because there are maladaptive ways people have of coping with chronic pain, and we're not trained how to address them. And so I think getting help from our psychology colleagues is helpful. And then eventually, what do you do for joint failure? Well, if you're lucky to have a joint that's failed where we have good surgery, then you send them happily off to the surgeon. I'd like to point out, just as a caution for everyone, that back pain surgery is very good for radiculopathy syndrome. So if you have shooting pain down your legs and arms, surgery is good. The outcomes are more 50-50 if you send someone just for central pain, right? So just a word of caution. And if you have it in joints where you can't do much, you end up with disability. And this is, I'd like to share another patient, because this segues into why I'm interested in the synovium and looking there. This is a 63-year-old woman I saw who had been previously treated with steroids and methotrexate for a possible inflammatory arthritis, because she kept having knee effusions and a lot of pain and hand symptoms. And so ultimately, though, hand exam and x-rays showed degenerative damage, and this knee effusion was aspirated multiple times, and it was clearly non-inflammatory, under 1,000. But what's always about these patients has always struck my attention is, while we were thinking about, well, she may have an inflammatory arthritis, she would get prednisone, low doses, and she would feel a lot better. And even though her diagnosis was OA, prednisone helped. And I'm not telling you to go treat OA patients with prednisone, because that's not what we do. But there is a subset of OA patients who have what feels like an inflammatory component to their disease. And so I think my question here is, OA really not inflammatory, right? I mean, 1,000 white blood cells or 600 white blood cells is not autoimmune arthritis, but it's also not normal. So what role does the immune system or inflammatory responses play in osteoarthritis? So just going back to my schematic, ultramechanics, tissue damage. Instead of pain, when you have tissue damage, you get inflammation. So not only is the joint getting damaged and you have intermittent pain, you're having intermittent inflammation in the joint. And the question in the osteoarthritis field is, does this matter? Is it a bystander, or does it actually cause something? And so we do know from multiple clinical trials, of which I've just, studies, of which I've just put a subset down here, that inflammation measured by multiple methods, which we'll talk about, in OA does associate with increased pain, makes sense. It associates with poor function, and it also associates with more rapid damage in joints where people have looked, such as in the hips and the knee. And the reason why people think this is because cartilage doesn't like to be bathed in inflammatory cytokines, right? So your normal cartilage, if you take normal cartilage and give these chondrocytes things like IL-1 or IL-6 or TNF, inflammatory cytokines, the chondrocyte changes. It changes from its normal anabolic state, where it's happily making matrix and sort of maintaining its matrix, to a very catabolic state, where it starts making more of its own degradative enzymes and making less of its own matrix. And so you basically have a situation where you have increased matrix turnover. And so this, as you might imagine, will predispose the cartilage to increased injury when you have more damage going on. So this is what the OA field thinks that inflammation could be doing to promote osteoarthritis. So this being said, I said that OA inflammation associates with bad things. We have a plausible biologic model of how it might be acting in arthritis. So let's try some anti-inflammatory drugs and see what happens. Well, we do know that NSAIDs work. There's multiple trials that show that they actually decrease pain at least. But people have gone on and looked at our RA drugs. So this is an anti-TNF inhibitor. These are two agents that block IL-1. These are the various sites they've looked on. Sometimes they're given systemically, sometimes they're given intra-articularly. Most of the time it's only for a short period of time, up to 6 months. And the results have been far from exciting, right? A couple studies, there's been a little bit of suggestion that there's been some decrease in joint changes or pain, but these are not long-term studies, and most of them don't reach significance, right? So thinking about the traditional way we use anti-inflammatory drugs to treat RA, it doesn't seem to translate to OA, right? But I would point out that we don't actually know what OA inflammation is. So, even the basic question, so how frequent is inflammation in osteoarthritis, right? So how do people measure this? Well, there's studies where they look arthroscopically and look just visually at the synovium and see if it looks reactive, and about 50% of OA patients will have changes. If you look radiographically, by ultrasound, in one study it was 11 to 31% had changes. By MRI it was higher. These, of course, varied by your stage of disease, which is always an important confounder. And then there's been histology changes that say that early OA patients none of them have normal histology, right? So what is the true estimate of inflammation in OA? And I think we just don't know. I will point out, just to show you that OA inflammation does exist in OA, I thought this was a really interesting study where they took synovial fluid and blood from either OA or RA patients and measured just one of our pathogenic cytokines in RA, IL-6, right? And so what you see here is very different patterns. So in RA, when you look at your serum, your blood IL-6 and your synovial fluid IL-6, they correlate. So the more systemic inflammation you have, the more inflammation you have in your joint. Interestingly, in OA, perhaps not surprisingly, there's not this correlation with blood response, right, because it's a local disease, but you have a huge range of IL-6 being made in these patients. And if you break this into quadrants, so because the axes are different here, these are patients who have roughly the same quartile of IL-6 response. And you can see here that although the serum levels of IL-6 are lower, there are many OA patients who have the same levels of IL-6 in their joint as does RA patients. So OA can be a quite inflammatory disease. So we set out to look at this a little bit more. So we start out with a basic thing. Let's just take some tissue from OA patients and chop it up and see what we see. Are all OA patients the same or different, right? And so we chose to use late-stage knee osteoarthritis, which is an easy source of tissue, and we take the tissue and we cut it into little chunks and we culture it overnight in the lab. And we do this for two reasons. So one reason is that we can look 24 hours later and just see what the tissue itself is releasing and do multiplex ELISAs where we can look at what sort of adipokines or inflammatory cytokines they're making. And then the other thing, we treat with a protein transport inhibitor, and then we disaggregate the tissue and look by flow cytometry to see what cells are in the tissue and what are they making by flow cytometry by their surface markers. And so when we did this, so we took 27 patients, and this was just a pilot stage of late-stage knee OA patients, and we made lots and lots of different markers. So we looked at, for example, the number of myeloid cells, or the number of different types of fibroblasts, or how much IL-6 or IL-8 they released, or how many adipokines they released, or how many lymphocytes there were. And we put them in a clustering algorithm, and you can see that when it's red-orange, there's more expression, and when it's blue, there's lower expression. And across 27 patients to our supplies, we started seeing clusters, and the clusters were quite different. So we had a cluster down here, which I sort of view as our lymphocyte cluster, even in OA. So these were more likely to have T cells in the joint, and these T cells were most associated with production of things that we think of T cell cytokines, such as interferon gamma and TNF alpha or IL-10. We had the other clusters were associated with more macrophages in the joint. One of these clusters by itself was just lots of macrophages, and one subcluster made a lot of adiponectin. for reasons that we don't really understand. And then we had a third subcluster that made lots of IL-6 and IL-8. And so I don't know what to make of this, except for I guess I proved that people are different. But on the other hand, I would say that we don't have very many ways to predict patient heterogeneity in OA, right? So can we use the synovium, which is a relatively easily accessible piece of tissue, to see if this tells us something about OA patients? Do these clusters, and we have lots of work to do here, so do these clusters, are these stable in early versus late disease? Can we, and I suspect some of these clusters are unique just to late disease, but maybe we can see signatures that predict certain patient populations in early disease. Are they different or the same between joints? And then, of course, what we're long-term interested in is, do any of these clusters predict patient outcomes? Can they help us sort patients? Because I think stratifying patients is the first step to then directing them to different treatment modalities. So, and just to summarize this end of the talk, I think I call this OA hopes, right? Because I think we're a lot farther away from, we're not very far in RA, we're not very close to patient-directed therapy in RA, and we're even farther away in OA. But I would propose that we need, the field realizes we need better ways to phenotype OA patients, and perhaps looking inside the synovium may give us better understanding of disease mechanisms and help stratify patients for interventions in the future. And so this concludes my talk, and I'd just like to thank lots and lots of people here. So in addition to my division, who has been incredibly supportive to me in my research, I'd like to potentially highlight Hannah Lebinsky, who was a very amazing journal medical student who did a lot of the OA phenotyping work, and Paul Panapinto also helped. The people in Boston who, my postdoctoral mentor, Michael Brenner, and all the people here who have helped in various projects, members of my mentorship committee, and then all of the osteoarthritis work would not be possible without the people at the Ben Arroyo Research Institute in Virginia Mason who have gotten me tissue samples, especially Jane Buckner, who leads their translational group. So thank you.
Great talk.
Thanks.
Two questions. One, what's known about the underlying collagen structure of patients like your gentlemen who seem to have OA everywhere? And two, you didn't say much about, you just briefly talked about joint injections, and there's some controversy there. Could you talk a little bit about injections?
Sure. So I would say for the collagen matrix part, I mean, that is, I know there's a large group here who's very interested in collagen matrix, so I might put my foot in my mouth talking about it a little bit, but I think we don't understand very much about it. And I think it's really interesting because we have to think about the matrix. As you see clinical patients, you look at patients who have early cartilage damage, so you have to think about the cartilage matrix, but you also have to think about these patients who have hypermobility, who the damage is in the ligaments, and those are two different matrices, and I'm hoping the people here will help us figure this out a bit more. In terms of joint injections, I think that's also a controversial field, and I think part of it comes out, I would argue, from the fact that we don't know how to stratify these patients very well. So we've all seen in clinic patients who get steroid injections or hyaluron injections, and there's a subset who do well. You won't hear from them from 6 months. And then there are other patients who get the injections and they're back a week later saying nothing helped. And then most patients get an early benefit, but then as the disease starts to progress, the injections wear off. So I can't quote you any literature, but I think it's part of the heterogeneity of disease that's made it very difficult to interpret those studies. Yeah.
Hi, Erika, very nice talk. In terms of targeting the fibroblast and fibrosis, there are a couple of drugs that are approved for interstitial pulmonary fibrosis, some of which are actually being tried for sclerodermal, including sclerodermal lung disease. What do you think about using those for either RA or OA to target fibrosis?
I think it would be really interesting. I think we would have to, I think in RA, it would be really, if these histological phenotypes hold up, where there really are these patients, perhaps the low CR patients who have a more fibroid phenotype, then those would be the patients I would sort of target in RA. I think just giving it to bulk RA patients, we'd probably lose the signal. But, so I think we need better phenotyping first, but I think it would be very interesting. Yeah.
Any thoughts on the sex difference for RA and what's smoking doing?
Smoking doing. Okay, I can answer smoking better. Sex difference in RA, I'm not sure I can answer at all, but smoking is smoking is a risk factor for the CCP positive disease, and CCP positive disease is associated with the major HLA genetic risk variants, so HLA, DR4, and DR1. And so having HLA, those HLA variants and smoking, massively, it's the shared epitope increases your risk. And the thought is to do with citrullination. So anti-CCP antibodies recognize citrulinated proteins, right? And the current model for CCP disease is that smoking in the lung drives citrullination of these proteins. And with the right HLA epitope, these citrulinated proteins get presented, and then you can make CCP antibodies. So that's the current model for smoking. Sex differences that.
Got one over on this side.
Yep.
So I have a lot of patients like the gentleman who was the heavy equipment repairman with multiple joints with osteoarthritis. You listed under the treatments NSAIDs.
Yes.
I didn't see acetaminophen there, and
my
understanding is that for many of these older patients where you might not want to use an NSAID, that the effectiveness of just regular old acetaminophen is comparable.
It is true, yeah. So I put that in my OTC pain medication, so I lump acetaminophen and NSAIDs together, and in older patients, especially, I reach for acetaminophen first, or the benefits in the actually current ACR guidelines for OA in terms of treatment of older OA patients list either acetaminophen or topical NSAIDs over regular NSAIDs because of the risk factors there of using chronic NSAIDs in that patient population. Right.
I have a question here. Thanks for your talk. I know you mentioned demographics is one of the factors that's involved, and the burden of rheumatologic disease in American Indian Alaska Native population is really high.
Right.
And I'm wondering if there, and I just don't know this, if there is data or even a trend towards understanding, like, do certain agents work better than other agents in those patients, specifically where that hasn't been the case and then now is very prevalent where in.
So we know that the prevalence of RA in Native American populations is because the CCP positive disease is because they have a much higher prevalence of these HLA risk factor alleles. I do not know personally of any data in the Native American population looking at if one agent is more effective than the other. I would say, I mean, by demographics, like CCP positive disease is more targetable by our appears to be more lymphocyte predominant, so it responds better to a broader range of probably agents that we currently have than some of the other histological phenotypes.
Great. Let's give Dr. Nass one more round of applause.